Thank you, Crystal, and good morning, everybody. Before I begin my presentation, I would like to let you know that I prefer to answer any of your questions at the end of my presentation. And as Crystal mentioned, please do not forget to click the evaluation link for us and fill it out for us. Thank you. Then today I'm going to talk about dysphagia and nutrition recommendations for head and neck cancer. And I have some information about the number of people who are diagnosed with head and neck cancer this year in the United States. According to the National Cancer Institute, head and neck cancers account for about 4% of all cancers. And this year has been estimated that 66,630 people will develop head and neck cancer. And it is estimated also that we're going to have around 14,620 deaths in the United States. And as you see these numbers, these cancers are more than twice as common among men as they are among women. And maybe you're wondering, why did I choose this topic? Unfortunately, my dad, a few years ago, has been diagnosed for cancer. And he just went through this problem, and almost we lost him because of, I don't know, I'm going to call it lack of our knowledge, and we didn't have a right dietitian. And in 5 months, we lost him. That's why I love and I do always some researches about this topic, and I wanted to just update myself, and I would love to maybe treat my patients in future and just let them have a quality of life for the future. Head and neck cancers are specifically defined as cancer of the upper aerodigestive tract, which includes the lip, oral cavity, nasal cavity, paramucosal sinuses, pharynx, oropharynx, hypopharynx, and larynx. And as you see, head and neck cancer patients often experience malnutrition before and during their treatments, which ultimately results in altered body composition and sometimes may worsen some of their clinical outcomes. And it is associated with significant disability, morbidity, and mortality rate in this group of patients. And I found out that 40% of newly diagnosed to head and neck cancer are malnourished. And weight loss and altered nutritional status are evident, and unfortunately 50% of this kind of patients. And unfortunately, physicians do not address this issue. Then we, as a dietitians, we should be very creative and just be there and help this kind of patients and prevent any complications in future. And malnutrition can occur for many reasons. For instance, if a patient doesn't have adequate nutrition intake, and because their nutrient demand is increased, those demands are not matching with intake. Sometimes alcohol and tobacco use can be the reason. Sometimes poor dentition. Complete or partial impairments of swallowing or chewing can cause some malnutrition. Sometimes tumor-induced derangements. Sometimes xerostomia, mucositis, and dysgeusia. And most of the time, chemo and radiotherapy are the most common causes of malnutrition. And we have some signs and symptoms, which is caused by cancer, will vary depending to all these patients. It's just, we have some general signs and symptoms associated with this type of cancer, like cachexia, pain, anorexia, disturbances in electrolyte metabolism and water, progressive impairments of vital functions, sometimes weight depletion and weight loss. And dysgeusia and dysphagia is very common, in this group of patients. According to all the studies, usually many people who have a surgical resection of head and neck cancer unfortunately result in chewing and swallowing difficulties. And as I said, dysphagia is very common, aspiration is very common, and negative nitrogen balance sometimes can happen, and communication impairment is very popular in this group of patients. And other patients who receive chemotherapy usually experience nausea, vomiting, diarrhea, chylosis, glossitis, anorexia, and esophagitis. And mostly, as we mentioned, in more than 50% of this group, all the symptoms are happening. In addition, majority of people who receive radiotherapy also experience xerostomia or dry mouth, mucositis, dental caries associated with xerostomia, adenophagia or pain in swallowing, dysgeusia or loss of taste actually are more common with patients who are going under radiotherapy. I chose 3 studies. One of them was about dysphagia treatment for patients with head and neck cancer undergoing radiation therapy, which was published in 2018 by ELISA. The purpose of this study was to find out that those patients who were going under radiation therapy with or without chemotherapy for head and neck cancer often develop dysphagia. And interventions from speech-language pathologists aimed to improve their swallowing physiology and function. As we see, speech pathologists are playing an important role in this group of patients. Then we have to at least refer a patient as soon as possible as a dietitian or a physician to a speech pathologist to prevent any complications in future. They researched 7 different databases for all primary studies that included in this following. Number 1, it was a behavioral swallowing intervention for head and neck cancer patients who treated with chemo and or radiotherapy. And the second, they created a comparison group and outcomes related to swallow physiology, function, and also they just compared their quality of their life too. And finally, they come up with descriptive analysis conducted for all outcomes that were identical in types and time relative to chemo and radiation therapy. And for results across the study, the results show dysphagia treatment varied by exercise type and start time before or during chemotherapy or radiotherapy. Then it is important to just make sure when radiotherapy starts, how we're going to treat and how we're going to just go through all the nutrition care process for all these patients. And after treatment, that outcome measures varied by domain, tools, and follow-up schedule immediately after or within 3 months. This 3 months is very crucial for this type of patients. And the analysis revealed functional benefits after intervention with early and late time start. And here's my second study, which is about influence of radiation dosage to pharyngeal constrictor muscle on late dysphagia and quality of the patient's life with locally advanced oropharyngeal carcinoma. In this study, they are just going through all of those patients who are having oropharyngeal carcinoma. And the purpose of this study was to find out that those patients with oropharyngeal carcinoma often have difficulty swallowing. As we see, this is very common in all this group of patients, which may affect their quality of their life. And radiation dosage to constrictor muscles play an important role in the whole process of care. They evaluated around 54 patients with locally advanced oropharyngeal carcinoma, and data were collected using the questionnaires within 2 years. They collected all this information within 2 years. The pharyngeal constrictors showed that were identified as an organ at higher risk for this type of patients. An influence of radiation dosage to the constrictors were analyzed on late dysphagia and quality of patient's life again. And for the results show that late radiation-induced dysphagia depends significantly on the dosage to the lower pharyngeal constrictor. Then the lower were at higher risk. And late dysphagia is also dependent on the dosage level of the middle constrictor muscle. Then we see that middle and the lower pharyngeal constrictor are at high risk of all this process. And the conclusion was that radiation dosage to the upper constrictor muscle appears to be a little relevance, but the middle and the lower constrictor, as I mentioned, was given a special consideration to avoid late dysphagia. And long-term quality of life was dependent on radiation dosage. And the last study is about radiation associated with chronic dysphagia assessment by flexible endoscopic evaluation of swallowing in this group of patients, which is published in 2018. And the purpose of this study was to aim and to restore dosage volumes parameters of swallowing related structures. By evaluating long-term swallowing dysfunctions after radiotherapy in head and neck cancer patients. And for materials and methods, they chose head and neck cancer patients whose pharyngeal region was treated with chemo or radiotherapy. Also, they chose those patients who went under objective swallowing assessment by flexible endoscopic evaluation of the swallowing. This time, in this study, they evaluated 55 patients at the median of 20 months after their treatments. And according to the results, inferior and middle pharyngeal constrictor were significant predictors for dysphagia. Then we see with all this article that lower and middle constrictor were significant predictors for dysphagia. And in conclusion, they found that dysphagia correlates strongly with dosage volumes parameters, and pharyngeal constrictor was found to be significantly associated with dysphagia again. And here I just went through all the nutrition requirements and as a dietitian, how we can help this group of patients. And for nutrition requirements for this group, it's recommended that early nutrition support should be offered in the treatment process because it has been reported to reduce some complications in the future. And main substrate that provide calories for this group of patients should be carbohydrates and lipids. And as we know, protein intake should be just determined by severity of catabolism of every patient. And sometimes maybe depends to the patient's metabolic stress and rate, we have to come up with parenteral nutrition. It is very rare, but sometimes we have to just go with parenteral nutrition. And timing of this nutrition support is very essential and important to just prevent and maybe stop some of the complications in future. An assessment of this nutritional status should be based on subjective global assessment result. We have to go through every step and find out more and more about these patients. And we should remember that nutrition therapy recommendations are vary throughout the continuum of care for these patients. And the primary goals of nutrition therapy are to prevent, as I mentioned, to prevent and reverse nutrient deficiency, and to help these patients to tolerate their treatment for the whole process. And we want to make sure that we're going to minimize nutrition-related side effects and complications. And we wanted to help them to recover and heal as soon as possible, and maximizing their quality of life. And as I mentioned, nutrition is playing an important role in this type of patients. And we have to make sure that we're going to provide adequate amount of food during and after treatment for every patient for this group, to make sure that they are feeling better and staying stronger. For instance, energy requirements should be around 15 to 20 kcal for every kilogram a day to prevent refeeding syndrome, because it is sometimes common in this population. And if we wanted to maintain their weight, we have to come up between 25 to 35 kilogram for a day. And if we wanted to just make sure that they're going to gain some weight and not losing weight, we have to come up between 35 to 45 kcal. And for protein, as I mentioned, it is different for every individual. It's between 1 to 2.5 grams for every kilogram, to just make sure they are getting adequate protein. And nutrition in this type of cancer can be challenging due to the cancer itself and its treatment. I had that experience and I know how it goes. It's just difficult. And the use of texture modified foods and thickened liquid has become a cornerstone, and all depends to the patient's dysphagia level. And enteral nutrition is preferred among this group of patients because scars and lesions in their oral cavity makes it very difficult to consume food orally. Here I thought to just come up with the image, and it's more easier to just follow up what kind of nutrition support we have to come up with these patients. For pre-treatment, we have to always make sure we're going to go through all the process for nutrition care and do the nutrition screening, just gather some history about their weight, if they are losing weight rapidly or they are just staying on their weight. Just we wanted to make sure we're gathering all this information, and physical examination is very important to just do it for these patients. And lab, we have to make sure that we go through all the labs and see what is changing. And if we found out that they are acute malnourished, then we're going to just look at their therapy, if it's intensive or it's not. If it's not, then we're going to choose oral supplements. But if we found out that they are moderately or severely malnourished, then we're going to just look at their nutritional support, if it's aggressive or it's not. If it is, then we're going to go with their GI tract functional. If it's functioning appropriately, if they don't have any problems with their gut, we're going to choose oral support or enteral tube feeding. And if, unfortunately, their gut is not working, we have to choose parenteral nutrition. And for parenteral nutrition, I just come up with this image, and I thought it's more easier to follow up if they are going to have a peripheral parenteral nutrition or total parenteral nutrition. We have few options like NG tube, G tube, J tube, NG tube, and ND tube. And as a dietitian, we have to just, again, trust our judgmental and go with whatever it is necessary to help this kind of patients. And in summary, I just gather all this information to make it more easier for this kind of patients. These patients often face multiple nutrition challenges before, during, and after their treatments. And common treatment-related side effects such as dysphagia, adenophagia, dysgeusia, xerostomia, mucositis, nausea, and vomiting all impair the patient's ability to maintain their adequate oral intake. And as we mentioned, malnutrition and intentional weight loss in this kind of patients during and after treatments are associated with poorer treatment outcomes, and it increases morbidity and mortality and poor quality of life for this population. The main nutrition goal for these patients is to minimize the complications and maximize nutrition intake either orally or through the nutrition support therapy within the 3 months in order to prevent some of the complications. And as we should remember, as a dietitian, a personal nutrition plan should be based on patients' metabolic status, likes, and dislikes. Here are my references. And if you have any questions, please ask me and I'll be happy to answer all your questions. Thank you.
Thank you, Flora. It was a great presentation. As you see, I put in the evaluation link for Flora's presentation. If you could please fill that out before heading out to the next breakout rooms. At 10:25, we have Amanda presenting on plant-based diet effects on heart health, and Lauren will be presenting nutrition and preterm infants. If you have questions, please feel free to put them in the chat box, and Flora will be taking them as they come in.
Thank you, Crystal.